There it goes. All right. Thank you so much. My charge today is a little bit different. I'm Susan Persky. I'm coming to you from the Genome Institute at the National Institutes of Health, where I'm in the intramural research program. I see my slides down there, but not up here. Probably because I need to do this. Okay, this works. So I'm going to talk today about choosing comparators. So if we think about what Brennan was presenting about the VR 1, 2, 3, another way to think about the clinical translation pipeline is to start a little further back, kind of take a little bit more of a holistic view, and start with more of the basic research format, where we think about these tools we have. And we have XR. We want to help people in various clinical situations. We can do basic research to start thinking about, and this is work we've been doing for, I think we pointed out the last 20, 30 years. Could it even work? Are there things about XR that are useful in clinical care? And then we can move on to asking questions like, does it work? And these are our efficacy trials and what I'll mostly be talking about today. And then once we have interventions that work, we get to move into the making it work piece of this pipeline, where we take our efficacious interventions and we move them into the messy real-world healthcare setting. So I would argue that in our ecosystem, we are probably in most cases somewhere right about here, where we're trying to design sort of the best trials we can design and determine whether and when these tools that we're developing are going to be efficacious in healthcare settings. Of course, we're not only going to ask, does it work? Right? There's a lot of questions we need to ask as we're doing this work. We need to know, how does it work? We need to know, for whom does it work? And Lindsay will get into that in a little bit. And we need to know, compared to what? Because it's never going to be in isolation that we're asking the question of, does it work? Bigger question I think we need to ask first is, what do we mean by it? Right? So by it, we could mean XR. And we talk about it a lot in that way. So we'll say, virtual reality is a treatment for ADHD. Virtual reality cured my fear of heights. Virtual reality didn't do any of these things. We don't say, take 2 virtual realities, call me in the morning, right? Virtual reality is not medicine. So I think of, I'm going to say VR because I work in VR, but we can expand this to XR. So XR is this enabling tool. A lot of people use a syringe metaphor. I like a capsule metaphor for XR. So if we think about our hardware as a capsule, there's going to be a compound in that capsule that's going to be part of the medication, but the capsule can be active too, right? It can speed up delivery of a drug, it can slow it down, it can do different kinds of things. So we really need to think about this a little bit more holistically, but something else we need to think about is, what is inside of that capsule? What are we putting inside the headset that people are using? Because it makes a really big difference if people are putting on a headset to look at a very relaxing ocean scene, play an interactive game, or maybe interact with a virtual human, right? These are completely different experiences, but they might all take place with the same hardware. So when I talk about it and thinking about whether it works, what I'm really thinking about is this sort of holistic idea of our content. We're going to talk about our hardware, the algorithms that tie all of this together, as well as some aspects of the context that might be really important when we're giving this, say, to patients. And then, of course, in the middle, we've got these sort of synergistic effects that all of these things can kind of bring together. So just to level set, this is what I'm talking about when I'm talking about testing for efficacy. So now we can take our it, right, and we need to compare it to something to determine whether it works. So I'm going to be drawing very heavily on a paper that I published with my collaborator, Luana Kaloka, last year. So if you want more information, there's a lot available there as well. So in this paper, one of the things we talked about is when we are evaluating any kind of intervention in XR, one of the things we need to pick is, how are we going to design our trial? What are we going to compare that intervention to? There's a lot of options here. I'm going to walk through them. But one of the really important things, I think, particularly with what Aubrey was just presenting, is what kind of claims are we actually able to make after we conduct our trial, if our results are positive? So what can we actually say about our intervention after we've tested it? So we have seen a lot in the XR literature. We've seen this no control situation, right, where we look at an outcome, we give somebody an intervention, and we remeasure that outcome. And in early stages, that is great and useful, and we've seen a lot of it. And what we can say is that our outcome has changed. We don't know why our outcome has changed, but it's changed. Somewhat similar is we can use our no treatment control. So sometimes we give that other group nothing. Sometimes we put them on a wait list to get an intervention, but essentially they're not getting anything. And when we compare that to our intervention, we can say, okay, our intervention's better than nothing. And sometimes that could be totally appropriate if clinically the other options for a condition, for example, are nothing. So we may want to know that, but for the most part, as I'm sure most of you are very aware, these kind of designs are not really likely to answer the kind of questions that we have right now. Certainly doesn't mean they don't have their place. Something that's becoming more and more popular, I think, in this environment is to compare our XR interventions to an active comparator or a treatment as usual. So what else is available clinically? We can compare it, our XR intervention, to that and see if it's better. But in a lot of times what we're actually trying to do here is determine if it's sort of just as good. If it's equivalent, that can be actually better because maybe our XR intervention has a better profile of side effects, it's less invasive, it may have other benefits that XR particularly can bring to the table. Now where I'm really going to focus today are on these last two. So this one, it's called a specific factors control. It's probably more than you need to know, but basically what we're trying to do here is we have one factor we're really interested in. In our world, usually this means the hardware. This usually means, VR or AR, and we want to know if that improves our outcomes. And then we have our placebo control, which we often think of as our gold standard. Obviously, it really depends on what we're trying to say at the end of the day, but here we're saying we sort of know what our active ingredient is, and that's useful to us. So I'm going to actually focus, so all of these, I think, can answer a lot of the efficacy questions, assuming that our trial design is matched to what we want to say at the end of the day, right? Okay, so you probably know most of this, but what I really want to focus on today are these last two, because I think this is where the art and the science really come together. Because MXR trials are actually really, really complicated. And so we have to think a lot about what our comparators are going to be when we're doing these two types of designs. So just to start here, first thing we need to figure out what's our active factor, right? What's active, what's inactive. It's important in both of these designs. And if we look at it holistically, our active factors can be in any part of these. That's part of what makes it so complicated. And in the paper that I showed you earlier, we came up with a bunch of things that, we call them XR specific. It doesn't necessarily mean they don't belong elsewhere, but these are things that often are what drive effects in XR interventions. So things like presence, embodiment, the fact that our interaction can be behaviorally driven, closed loop systems, form factor, things like that are really well aligned with XR. But we often kind of forget about all of the rest of the things that go into interventions, whether or not they're XR. And these are all really, really important. And we can't forget about these things just because we're using a novel technology. So I'm going to give you a couple examples. So first we'll start with this specific factors control. And just for fun, I went back to my dissertation, which I did in 2003. And my dissertation was on violent video game effects in VR. I programmed this game. Took me way longer than it should have. But it's basically sort of a prototype violent game where you're shooting at people across the room. They're bleeding, they're dying, right? So what we did for this was compared sort of our headset, our $26,000 headset at the time, to a desktop computer monitor. And what I really wanted to know is, does playing a sort of violent video game in VR make you more aggressive? What we did here was really just manipulate one specific factor, and that is, do people wear the headset? In both conditions, we used the arcade gun in both conditions. We kept it as constant as we could, and really just focused on this, do they wear a headset or do they not wear a headset? You'll have to talk to me after for the results. Another study we did, I want to show you that it doesn't have to be just the headset, right? To look at one of these factors. Another one was to compare violent and non-violent games. So here we designed a non-violent game to go along with this violent game, doing the same thing. We're pressing a trigger, we're shooting a gun, but here we're displaying it as spray paint. So we're making an artistic creation across the room, doing the exact same activities, and looking at outcomes compared between the two. So this is another example of a specific factors control. So that's pretty simple. The placebo control is where it gets really, really tricky, right? And I think we all know what a placebo is. We talked about it this morning. I'm putting a definition up here just so that we're all on the same page. That comes from the National Cancer Institute. But basically, in order to effectively do this, let's see. Oh yeah, okay. We need to figure out what our active factors are. What on this list is what's really driving our intervention, and a lot of times, that is not easy, right? Because we're not talking about a compound inside of a pill. We're talking about a behavioral intervention. We're talking about something that happens in a healthcare context. We're talking about a lot of pieces coming together. So this is why it's an art and a science. It's never going to be super cut and dried. And a lot of times people will say, okay, well, can we have a universal comparator, a universal sham VR? And I would say probably no, we can never have that. And that's because when we have an XR intervention, it really matters what's going on in that intervention in terms of what our comparator needs to be. So if we think about our distraction-based acute pain management in XR, we might really think that things like presence and multisensory stimulation, engagement are really driving those effects. But we can compare that to our gamified physical rehab, right? And here, we're probably focused more on embodiment, perhaps, the fact that our engagement is behaviorally driven, we might have a closed loop system. So we have all of these other things that are probably more likely to be driving our effects. And those are the things we're gonna have to focus on. And then we have, of course, everything else here, which may be an inactive factor, it may be somewhat active. We're gonna have to decide how to handle each and every one of these. And this is not, this is a short list. So this is hard. This is a hard problem. We have to do a lot of work to figure all this out. Why do we care? Why do we need to capture placebo? Why do we care so much about placebo effects in our trial? And how can we start to understand those effects? So we got some examples of placebo effects this morning. I'm gonna give you one of my favorite, just because I can, and how powerful this really can be. So colleagues of mine gave a situation where they brought people into the lab. They gave them a sham genetic test. So they actually scraped their cheek, they ran the test, but they actually ended up randomizing people and told them that they had a genetic propensity to have either a high satiety response or a low satiety response when eating. They had them drink a milkshake, and then they measured a bunch of outcomes. I'm gonna focus on two. First is the self-report, how full do you feel? And the second one is GLP-1 response. So this is the hormone. We were seeing a lot of focus on that right now with some of these new drugs. It's this hormone about satiety. So those who got results saying, your satiety response is low, it might take you longer to feel full, they saw no change in their self-reported fullness and their hormonal response when drinking this milkshake compared to a pretest of the week before. Those who were told they had a high satiety response not only felt more full and reported feeling more full, but their GLP-1 response went up 2.5-fold, right? So as we saw this morning, we get not only our perceptions, but we also get changes in biology. And of course, this is completely regardless of their actual genotypes, which, as it turns out, were less powerful predictors of response than the placebo effect. And then just for the other side of the coin, we can talk about a nocebo effect, which is this idea that an inactive intervention, so sort of a placebo, that can cause negative effects because the patient believes they're going to be negative effects. And this study, I think, is kind of fun because it's in the VR context. So in this study, Mao and colleagues, they brought people into the lab, prepared them for a VR experience, and they did what we often do. They warned them about cybersickness. They said, you may feel cybersick from VR. Now, they actually randomized folks to condition, once again. Some people got no warning at all. Some people got a warning, but then they were told, which is what we do in our lab, we say, oh, but it's really rare, so don't worry too much. And then other people got a warning that it's pretty common. And then they played a game that's known to often induce cybersickness, and then they measured their SSQ score, so their level of cybersickness. So those who got the rare warning, the reporting of cybersickness after playing the game increased 2-fold. Those who believed that cybersickness was a common reaction to this game saw over 6-fold increase in cybersickness. It's gonna change the way that we give people warnings, isn't it now, right? What people are expecting is what we tend to see. Okay, so we know this is super powerful. Do we need to worry about this in XR clinical work? Well, I'm going to say yes. And part of this is what Toros and Firth call the digital placebo effect. So this was developed in a different context, but the idea here is that our beliefs and emotions about novel technologies as an aspect of an intervention produces expectancies and produces a placebo effect all on its own because it's technologically advanced, it's new, it's novel. Importantly, this really actually depends on people's attitudes about the tech. So if you don't think the tech's going to work, then you're not going to really get this placebo boost necessarily. So next question we need to know is, what do we know about people's attitudes about the use of immersive tech for health? So a month ago, I would have told you basically we don't know anything. There's no data out there. But I saw a great talk at the IFRA meeting last month from a group from Think Next and Holland Partners who actually did a really good study of market research about people who want to try VR in various use cases. And so what they found, and this is US data here, is that for use at home, managing chronic pain, on average, about 28% of participants in the study were saying, yes, I'm ready to try this right now. Corollary being that they think it's going to work. And then similarly, a somewhat smaller number, but about 21% said that they're ready to use this in the clinic for a painful or stressful procedure. So yeah, I think we're going to see some tech-based expectancies. It's not going to be universal. Probably as Brendan was talking about, maybe some of the more early adopters are ready to use this, but it's going to be important to separate out and to understand. So now we're moving on to XR placebos. So a lot of times what we think of when we think about this is sham VR, right? So sham VR we can think about as a comparator designed to mimic our active XR intervention, where we remove our active factor or we reduce it in efficacy. How do you take something out of an XR intervention and have it be something you can hand to somebody and take home? I mean, that's a big problem, right? That's something we really have to think about. And again, this is where art comes into this. What do you put in there? So there is one study that was recently published looking at how people handle digital sham in neuroscience therapeutics. Cool thing about this review is about 40% of the studies that they reviewed were XR-based, and 22% of them used a digital sham. And I'm putting up here some of the approaches that people took to create these digital shams. Mostly, they're replacing that active piece with something they're judging to be inactive. But that judging piece is really important because Boston colleagues reported that none of the studies that they reviewed actually reported validating those shams. Not a single one. Doesn't mean they didn't do it, but it wasn't reported. And it was really rare for them to report having evaluated any of those shams for equivalence on really important things like engagement and plausibility. So there are a lot of ways we can go wrong when we're creating these XR shams. And I'm just going to go through 3 of them to round us out here. So the first one I think we really need to focus on, number 1, ensuring our sham is not therapeutic, right? We don't want to mask our treatment effect by giving another comparator that's going to work. Now, one way that we tend to want to do this is to grab a commercial off-the-shelf product and give that instead. That could be a misstep. So just as an example here, this is a study by Fish and colleagues where they showed that just prescribing a casual puzzle game on your phone, something that we might reach for as, say, a comparator, actually in their sample reduced anxiety significantly over time. None of these games were designed to reduce anxiety, but it doesn't mean they won't do it. Another thing we need to focus on is ensuring that our sham does not create nocebo effects, right? If our sham makes things worse, we're going to create an artificial floor for comparison. That is no longer a fair study. Give you an example of that. This is a study from 2019 where they were comparing a couple of mental health apps to a control condition that they thought would be kind of neutral. They called it a reminiscence approach, where folks were using a list-type app to just record thoughts about the day. It turns out that people who did this really often had more anxiety when they did this. Now, there's reasons why the researchers think it happens. It doesn't really matter. This was meant to be neutral. It was not neutral. So then if you go in and compare the two, that's not really a fair comparison, because in the control condition, you've now made the symptoms worse. And then the final thing I'll talk about is ensuring that our sham is plausible and it creates expectancies that it's going to make people feel better. If we're going to make a placebo, we don't want to not activate placebo effects, right? That's the whole purpose. This one's a little bit more complicated in terms of an example, but basically this research group, they were giving some research participants either a placebo or a nocebo, and what they were doing was changing how that placebo or nocebo was given. So in the case of the placebo condition that was given in a way that was consistent with expectations, it was a cream, it was given by a healthcare provider who seemed plausible, who seemed competent. It's what you would expect, right? And here we saw no increase in symptoms. For those who got the placebo given by a healthcare provider who seemed kind of incompetent, didn't know what they were doing, it was not what people were expecting, and it didn't work. You didn't get the placebo effect. Point being that we need to make sure we're actually activating what these placebos, and we're giving people something that's consistent with what they're expecting. If we give them something that doesn't seem like it's going to treat the condition, then we're not going to activate placebo. So to wind up, just a few considerations to think about as you're designing or thinking about what a sham condition might look like. We need to make sure we're harmonizing these non-active elements as well as we can. We need to make sure our sham is not therapeutic, but it's also not detrimental. It really needs to be, neither of those things. We need it to be plausible and consistent with people's expectancies about what is actually going to work to make them feel better. So if we can do that, we can design studies that much more quickly are going to help us determine whether we have efficacy and effectiveness of our intervention. So we can move on from this does it work stage and start putting them into the real messy healthcare settings and determining how to make these interventions work for us. So that'll end it for me. And I'm going to go ahead and introduce our next speaker.